My name is Rakesh Patel. I'm a Clinical Associate Professor in Medical Education at the University of Nottingham. In my role, I'm Course Director for the Masters in Medical Education, and I'm also Academic Programme Director and Research Lead for trainees and students who are interested in medical education research. I'm also an honorary consultant nephrologist at Nottingham University Hospital's NHS Trust. In my clinical role, I take responsibility for patients with acute kidney injury, chronic kidney disease and established kidney disease on dialysis. The topic of my merit rounds essentially focuses on charting, which is the formal way, or informal in some contexts, way in which we document our evaluations and management of patients who present for medical attention. Now, charting is gaining more and more attention as the association between clinical reasoning and diagnostic error becomes more established, and individual as well as team-based factors begin to gain more attention. Charting also is something that isn't formally taught at medical school. However, students are expected to master the skill by the time they reach graduation. The presentation discusses many of the challenges around clinical reasoning, how we make sense of it, based on our previous understanding from classrooms and experimental contexts, to actually how clinical reasoning manifests and is applied in practice. The take-home messages from this presentation are a few. Firstly, charting is a really important form of evidence of clinical reasoning as applied in practice, but there are others, and I think there's an opportunity to look at diagnostic reasoning and management reasoning in all the events, experiences and encounters that take place in the workplace. Secondly, traditionally the focus of clinical reasoning in terms of outcomes has been making a diagnosis, but now I think there's a greater understanding that process outcomes are also important, such as the way in which we come up with a differential diagnosis, as well as the way in which we synthesise our thinking either as individuals and teams in the form of a problem representation, and maybe these now represent targets for educational interventions. And thirdly, with respect to educational interventions, as our theoretical understanding of clinical reasoning deepens and the evidence base around educational interventions in the workplaces also increases, I think there's a new opportunity for doing things differently in terms of improving the diagnostic capabilities and performance capabilities of trainees and doctors in the workplace. Finally, to find out more about some of the things we've talked about during the presentations, I'd target the audience to perhaps look at some of the resources that are freely available on the Society of Diagnostic Error in Medicine, which provide a whole gambit of handouts, resources, toolkits and checklists around clinical reasoning and diagnostic error in the workplace.